Good morning and welcome everyone. So this is session 4 of our RaCEEs course. Today we are covering the outcomes. So we're going to talk about cost effectiveness decisions, the QALYs, and all other clinical or cost effectiveness outcomes that we might use in economic evaluations. Today I'm running this session with Misael, and we are going to split this session in two. So I'm going to talk first about the cost effectiveness play, and then Misael will talk a bit more about cost effectiveness decisions, and then I will introduce you to the difference between clinical effectiveness outcomes, composite outcomes, and then Misael again will talk about the QALYs a bit more in depth, and then we'll conclude today's session with some final remarks and, of course, some homework information. Uh, Before we do that, do you have any burning questions about the homework post session 3, so post the session on costs? If you got any quick questions, we're more than happy to answer those questions. Okay. If not, you as you know, you always got a chance to, let your team leads know during the week through Teams or by email if you want any questions. If you need any feedback on your homework, we're more than happy to provide you with that. So please let your team leads know. Okay, so you will now be familiar with this slide. So we are now in session 4. We're going to cover another topic related to the method of an economic evaluation. So last time we covered costs, and this time we are going to move on to outcomes. We are still within the method section of our commentary. So all the information we're going to talk about today that you're going to extract as part of your homework will be part of the method section of the commentary that we are going to write up after the workshop. From next session, instead, we are going to focus a bit more on the results. So session 5 will be about the analysis and interpretation of the results. So the aim for today's session is to identify and describe the characteristics of the outcome data and the type of discounting used in the economic evaluation. As I mentioned before, I will cover briefly the concepts around the cost effectiveness plane, how we interpret the different results in a cost effectiveness plane. Then Misael will describe some examples of cost effectiveness decisions. I will try to again outline the differences between clinical effectiveness outcomes for cost effectiveness analysis and cost consequence analysis, and composite outcomes, which are instead used for cost utility analysis. Then Misael will talk about the QALYs a bit more, and then we'll finish with some explanation around discounting. So this is the outline for today's session. You will be familiar with this slide. So we covered cost last time, and now today we are going to move on to the consequences, onto the outcome side of an economic evaluation. So we are still looking at things in a comparative way. So we're still looking at the outcomes for two alternatives in these simplified examples, and we are trying to compare what's happening on the outcome side. And also make some consideration around how cost and outcomes can be weighed against each other, basically. Now, this is a graph of a cost effectiveness play. I have to say, this is probably one of the most important graphs we are going to present throughout the whole course. It's probably one of the most important takeaways of the course because it really depicts in a succinct way the nature of the decision around the cost effectiveness. I'm going to describe the graph step by step, taking one element at a time. So if you consider the two axes, you got the vertical axis here and the horizontal axis here. The vertical axis is all about costs. So on the lower side, you got the new treatment, which is assumed or expected to be less costly. On the upper side, instead, the new treatment is going to be more costly than the alternative, which could be, for example, usual care. On the horizontal axis, instead, we are taking into account effectiveness. So on the right-hand side, the new treatment is more effective than usual care. On the left-hand side, the new treatment is less effective than usual care. With two axes like this, you're going to have a subdivision of the plane into four quadrants. Okay, so we are going to name these quadrants as northeast, southeast, southwest, and northwest. So each quadrant means something different in terms of the cost effectiveness decision. So I talked already about the costs and effectiveness, but let's now have a look at the joint consideration of costs and effectiveness together. So first of all, let's have a look at this quadrant, the northwest quadrant. In this quadrant, the new treatment is more expensive, but at the same time is less effective. So these are two elements that work against, let's say, the cost effectiveness of the new treatment. So the existing treatment will dominate the new treatment because it will be cheaper and more effective. So in this situation, we don't have really any doubt. We know the existing treatment will dominate the new treatment. The opposite scenario is in the southeast quadrant, where the new treatment is more effective and is also less costly. So in this case, the new treatment will dominate the existing treatment, okay? Again, little doubt here around whether the new treatment is dominating the existing treatment. The two quadrants instead where we have a bit more doubts are the northeast and the southwest quadrant. So we start with the southwest quadrant. In this case, the new treatment is going to be less effective, but also cheaper, less costly. So this is a situation where we have to consider whether it's worth accruing less health in order to save more money. In some situation, it might be worth doing that. In other situation, it might not be ethical to do that. So there is a bit of a cost effectiveness, but also ethical considerations we have to make in this quadrant. The most common quadrant instead is the northeast one. So the northeast quadrant, here we go. Yeah, the northeast quadrant is the quadrant where the new treatment is more costly, but at the same time it is more effective. So this is the most common one because usually when you introduce a new treatment, you will have a new cost to take into account. Could be training, buying new equipment, and so on. But at the same time, there is a promise that this new treatment could be more effective than what is offered currently as part of the healthcare system. So in this situation, a new treatment is more effective but more costly. And again, we got this trade-off. What do we do? Is it worth investing X amount of money to at the same time accrue more health and more health gains? So we got this trade-off between cost and effectiveness, which is quite common. And thankfully, we have a decision-making process which helps us to make a decision in these cases. This will be explored a bit more in the next session, session 5, where we will be talking about the maximum acceptable incremental cost-effectiveness ratio, and we will talk about the threshold, which is in place in the UK. So for now, this is just to give you a depiction of what's going on within the cost-effectiveness plane and how different quadrants are attached to different cost-effectiveness decisions. Some are quite straightforward, others are a bit more difficult to disentangle, let's say. Any questions? Okay. So if you don't have any questions, I'll stop sharing, and then Misael, you can start with your slides. Thank you.
Okay. Um, Valerio, I need to have a permission to share. Okay, good. Perfect. So let's think about this example. Let's suppose that there are two new cancer drugs available in the market that can be financed by the NHS. And let's say it's that drug A can extend life by 1 year and it costs £100, and drug B can extend life by 1 year and it costs £300. This is just a simple example. It could be £100,000. So it's just to make the number round. So which one to choose? Uh, we could be easily tempted to say, okay, drug A is the one because it costs uh, less than drug B, but both of them can produce the same uh, years of life, but with less money. Eventually, uh, we can think about this with a more realistic example. Let's say that drug B, instead of 1 year, can extend life by 2 years, and it costs £300. What we really need is a new concept, the concept of net benefit. The net benefit is the number of additional years of life compared with the overall NHS. And let's assume that the NHS can extend life by 1 year at a cost of £50. So this is what is called in the literature the opportunity cost, the cost at which the NHS is producing one extra year of life. Let's think about this as an average. We can say, okay, how many years on average is extending life the NHS? Okay, we can add that. And how many million pounds are spent in the NHS, and we can divide that. So let's think this as an average. Of course, the estimation of this is a more complex thing, but the average uh, amount that the NHS is producing one additional year is £50. Then we can compare this in terms of net benefit. So let's make this as a quick example. The net benefit of drug A is estimated as the following. At the price of £100, drug A can extend life by 1 year. Okay. With the same £100, the NHS can produce 2 years of life because each year is £50. So with £100, they can produce 2 years of life. Then the net benefit is something happened, sorry, with my presentation. Okay. Okay, the net benefit would be minus 1 year of life. Why? Because the NHS could produce 2 years, but with the same amount of money, we are spending in a new drug, which costs £100 and it can produce only 1 year. So we are withdrawing money from the system to produce less years of life than it currently is producing. So that is the reason you can say that the net benefit is minus 1 year of life. Okay. Now, what is the net benefit of drug B? The same exercise. At the price of 300, drug B can extend 2 years of life. Okay, 2 years of life. But with the same 300 pounds, the NHS could produce 6 years of life, 300 between 50. Then we subtract 2 minus 6. This is 4 years of life. Then the NHS will lose elsewhere 6 years of life to finance drug B, which will produce only 2 years of life. The net benefit will be negative. So this is an important concept because we are not only comparing the cost of the drug, but we are comparing this with the opportunity cost of what is producing, how many years of life is producing the system right now. Which one to choose? None of them. This could be the answer. Okay, let's assume that now this cost, opportunity cost is of producing 1 year of life is 100 pounds. So this is increasing. What will happen is that now financing drug A will be the same as the current system. So in this case, we will be indifferent of financing drug A or not financing drug A because it will produce the same years of life than the current system. However, we won't finance drug B because we will be still losing 1 year of life. What will happen is that what follows is that if the NHS can produce one additional year of life at 101 pound, 1 pound more, then financing drug A is cost effective because drug A can produce more years of life than the NHS is giving up elsewhere. So now we are comparing these additional years of life, and the net benefit is how many years of life they are producing with the same amount of money. Let's make this another example. If the NHS could produce one additional year of life at 200, we will be indifferent within choosing drug A or drug B. However, it could be shown that if the NHS could produce one additional year of life at 201 or higher, then drug B will offer greater net benefit than drug A. What happens is that which drug we will produce, we will choose, we will prefer, it will depend on this cost effectiveness threshold. So, and this is the summary. If the cost effectiveness threshold is 100 pounds or less than 100 pounds, then we won't choose neither drug A or drug B because financing them will reduce the years of life in the health system. So, and if this opportunity cost of or this cost effectiveness threshold is between 100 and 200, then drug A is cost effective because between this range, drug A will produce more years of life than the system is giving up elsewhere. And for cost effectiveness threshold higher than 200, drug B will be cost effective. And what is the takeaway of these slides? The takeaway is that we will be comparing new drugs against how many years of life or QALYs are producing the current health system. And this is Now, this is now in the literature as cost effectiveness threshold. So we will see in all our papers that we are reviewing that there is estimation of threshold according to health systems. And then, this is the following. And then we will decide against this threshold if the drug is effective or not. I hope this is clarifying. If you have any questions on this. Okay, Valerio, over to you.
Oh, thank you. Thank you, Misael. Let me share my slides again. Here we go. So Misael talked about cost effectiveness decisions where we try to compare costs and outcomes together. I'm going to focus a bit more on which types of outcomes we might see in economic evaluations. I think it's fair to say across the papers you are looking at during this course, there are probably quite different outcomes being analyzed. So it's good to get this overview of what outcomes you might see and how to interpret the potential results around these outcomes. So you will remember this table from I think session 2, where I was describing the different types of economic evaluations. And I'm going to focus more on the outcomes column today. So, particularly, I will try to explain the difference between clinical effectiveness outcomes, which are often attached to cost consequence and cost effectiveness analysis. So, clinical effectiveness outcomes are typically measured in natural units. For example, Misael was talking about life years gained before, but there are other examples we can see here like disability day saved, for example, or points of blood pressure reduction. For another type of economic evaluation, cost utility analysis, instead, we are dealing with a composite outcome. And with composite, I mean something that combines a couple of elements, which is quality of life and life expectancy together. So I will talk briefly about that in a few slides, and then Misael will outline a bit more the QALYs, which is the typical outcome measure which we use in cost of utility analysis. So clinical effectiveness outcomes first, they apply to cost effectiveness analysis and cost consequence analysis. They measure how good the interventions are. In a cost consequence analysis, usually you got all the different outcomes disaggregated, so they're listed separately. There's no real intention to try to have a joint outcome or try to calculate a single outcome of interest, but rather everything is listed separately. So it's kind of up to the decision maker to understand the relative difference, the relative value of the different outcomes that are presented in an economic evaluation of this type. There could be clinical process outcomes, so really the list could be quite long. In a cost effectiveness analysis, instead, there is a focus, a precise focus on a key clinical outcome of interest. That usually is the primary outcome measure of a clinical trial, for example. So if there is an economic evaluation which is run alongside a clinical trial, that economic evaluation might have the primary outcome measure of the clinical trial as the primary outcome measure of the cost effectiveness analysis there. All in all, in a cost effectiveness analysis, the aim is to calculate the cost per additional gain in health, whatever that gain in health might be. So you got some example here, for example, long-term outcomes like cost per life year gained. Again, some examples were given before by Misael. Cost per improvement in quality of life. But sometimes it's not possible to measure things in the longer term. So researchers might have to rely on surrogate intermediate outcomes, like, for example, cost per 1 point reduction in blood pressure, 1 kilo weight lost, and so on and so on. So these might all be indicative of what happens in the short term, but they might not reflect well what might happen in the long term. But again, for constraints due to the study design, often we have to rely on surrogate outcomes or intermediate outcomes. And then we have to use modeling to try to extrapolate things into the long term. So these are the typical outcomes, effectiveness outcomes for cost effectiveness and cost consequence analysis. Moving on to cost utility analysis, we are instead considering composite outcomes. So usually the concept we are using here is that of healthy years, a combination of quality of life, life expectancy. So we're trying to combine quality and quantity of life together. That's why we are talking about composite outcomes here. This concept of healthy years is operationalized by trying to estimate quality adjusted life years or QALYs, which you will have seen in some of your papers, I'm sure, and is the most common outcome measure in economic evaluation. So cost utility analysis typically aim to calculate the cost per additional QALY. The reason why QALYs are so widely used is because they represent a common metrics which can be used across different health or disease areas. And Misael will now talk about the way we calculate QALYs, and I think things will become clearer in terms of understanding why QALYs are such a common metrics. Um, but yeah, one of the main advantages that is QALYs represent a common currencies which can be used across different health disease areas. So you can try to measure the QALYs for an intervention in stroke care, diabetes, hypertension. So you got that common currency which can be used to then determine the relative cost effectiveness of different interventions across different health or disease areas. Another advantage of using QALYs, particularly for health economists, is that it's based on preference or utility, which are utilities in particular are very important in economics. In particular, utilities are attached to specific health states, and again, Misael will talk about this a bit more in a few seconds. But the fact we are able to value specific health states and attach a specific value to specific health states is very important from an economic point of view. So this is another reasons QALYs are so widely used. At the same time, there are a lot of criticism around the use of QALYs, which I will try to cover briefly later on. But for now, I just wanted to give you this overview about the pros of using QALYs and why they're so widely used. Any questions so far? Okay, and before I leave the next part on the QALYs to Misael, I just want to give you an example of how to extract and write up the info on the outcomes from a paper. So this is again the paper we've been using as our exemplar, the paper on advanced Parkinson disease. And when we looked at the paper, we read in the method section that the authors used as outcomes life years and quality adjusted life years. So it was a combination of cost effectiveness and cost utility analysis in this case. And when it came to write up the method of that paper in our commentary, we just used a sentence to describe what the authors did. In particular, we explained that the author used a Markov model, but importantly for today's session, we also noted that the authors use life years and quality adjusted life years. So this is how we simply extracted and wrote up the information regarding the outcomes from that paper. Okay, I'll stop sharing and then it's over to you, Miser.
Okay. The QALY is quality adjusted life years. This is for short for QALYs. And what measures the QALYs are? It's a combination of the extent of life and quality related and health related quality of life. So this comes from a questionnaire. QALYs are very helpful because it can compare across different diseases, conditions, areas, and have interventions. And it's really flexible and is based on individual preference utilities. QALYs are estimated as years of life. In my previous example, we just talked about how much can extend uh, a specific drug in a number of years of life. But now the QALYs will weight this by quality of life. Then this quality of life will be measured from 0 to 1, perfect health. And if the quality of life is 1, then 1 year of life will be equivalent to 1 QALY. So, and if the additional year of life will be measured at half of quality of life, then the additional year will be equivalent to half QALY. So this is the basic concept of how we measure QALYs. So if in the perfect world, if the quality of life is 1, both of them will be similar. So we will be comparing just 1 additional year of life. Okay. Then how we estimate QALYs, how we estimate this weight, this number from 0 to 1, how we estimate this. Okay, this comes from a generic health-related quality of life questionnaire. The more used is the EQ5D. So this is one instrument, but there are several instruments. Again, this is the most common. And this is applied to RCT patients, and it will produce utility scores. So these utility scores comes from the general population. So we have one measure from our patients, from the RCT patients, and we have one measure that comes from the general population. And we combine this, and we have these weights. Okay, let's make this a step-by-step process. The EQ5D have 5 dimensions, and it could be in a version of 3 or 5 levels. Okay, what are these dimensions? The mobility is the one dimension, self-care, usual activity, pain and discomfort, and anxiety and depression. This is the 5 dimensions. And the levels could be measured in 3 levels: no problems, for example, no mobility problems, some or moderate problems, or unable or extreme problems. So, and in the 5 versions, we have a more granular measures of levels from no problems, slight problems, moderate problems, severe problems, and unable. So we have these 5 levels. And each health state is then assigned to a score, usually from 0 to 1, by looking the scores from a value set that comes from the population. So let's see a basic example. Okay, this is the example for mobility question. The question is primarily like this. So under each heading, please tick the one box that best describes your health today. In the EQ by the 3 levels, we have mobility. I have no problem walking about. I have some problems in walking about, and I am confined to bed. So they can tick one of these 3. So, and the same for the other 5 dimensions. So we have in the EQ5D 3 levels 243 Hilbert states. So this is all the combinations that we could have with 5 dimensions with 3 levels. And the difference with the EQ5D 5L, 5 levels, is that the same questions will be graduated more in 5 levels, so more granularly. So mobility we will have, I have no problems walking about. I have a slight problems. I have moderate problems. I have severe problems, and I am unable to walk about. So the same dimension will be graded in 5 levels. And as a consequence of that, the EQ5D 5L has 3,125 Hell states. So this is the combination of these 5 dimensions and 5 levels. So you can see that the difference between the number of Hell states, so it's massive difference. So from 243 Hell states to over 3,000 Hell states, just for including 2 more levels in each dimension. Then we will have, let me check, that's the point, okay. Then this questionnaire is applied to 2 sets of people. So one set of people comes from our study, okay? So the RCT, for example, is applying this type of questions to the particular population. And this could be in any intervention. So this could be in interventions that measure cancer outcomes. This could be in interventions that measure hip replacement, coronary problems, and so on. So it could be implemented in all the patients, in all kind of interventions. But also we have this set of questions applied to the general population. So this general questions is applied to a representative sample. So this kind of a random sample from the population. And then we ask them how much they value different decrements in quality of life against the full quality of life. Okay? So, and then they produce this kind of tables. Let's check how this is a new paper that just came across in maybe 2 or 3 months ago, so in 2026. They performed this exercise. They sampled a population from all the UK, and they asked these questions, and they make an exercise to value full length, quality of life against to the decrements of each characteristics. So, and this table is not difficult to read. Okay, this is read in utility decrements. We have mobility in 5 levels, self-care in 5 levels, usual activity in 5 levels, pain and discomfort in 5 levels, and anxiety and depression again in 5 levels. And you can see here that each level 1 is valued at 0, 0 decrements, 0 decrements, which means that if one individual has ticked the first level of each of them, then 1 additional year of life will be valued at 1 QALY. So it's equivalent, both of them, which means we are not decreasing any length of life because of quality. So 1 year of life will be equivalent to 1 QALY because we are not reducing, we are weighting this at 1 because we are not reducing any utility from any of these dimensions, because all of them are valued, are reported at level 1, so which is non-problems, no problems at all. Okay. If there is a mobility level 2, we will have a decrement of 0.032, so which means a marginal reduction of less than 3%, of 3%, more or less, okay? So the higher the utility decrement, the higher the penalizing of reduction of QALYs. So this is how we read this, and we add, this is an additive utility function. So you can see also that each level is increasing. So for example, from mobility level 2, 0.032, level 3, 0.058, level 4, 0.179, level 5, 0.27. If you like, you can read this as percentage, of course. Mobility level 2, a reduction of 3%. Mobility level 3, nearly 6%, 18%, and 28% reduction. Okay. For example, if one person takes level 5 in mobility, and then the others in level 1, 1, 1, 1, 1, then the quality of life will be reduced by 28%. So one additional year of life will be equivalent to nearly 81 QALYs. So this is a dot 81 QALYs, so less than 1 QALY. And according to this table, we can see that pain and discomfort is the dimension that is reducing more QALYs. This is pain and discomfort are more valued in terms of QALYs. Why? You can see here, pain and discomfort, the level 2 is 0.056, which is higher than all the level 2s across the table. Okay? And the component of these different levels is higher in pain and discomfort level 5, which is 0.47. So 48%, nearly half of QALYs. So if one person experiences pain and discomfort at level 5, this is nearly reducing the QALYs in 50%, nearly. So pain and discomfort is the most valued in all these dimensions, and also the level 5 of pain and discomfort is valued most, which means are reducing more QALYs across the table, and this is additive as we observe. So, and note that the worst health status is minus 0.567. So how we obtain this number? So we subtract 1 because we are reducing. We need to reduce 1 is the full length of life, and we pick mobility level 5, 0.279. Here it is. And then we subtract all the worst scenarios in each dimension, and we will get this number, minus 0.567, which is less than 0, which is, we conceptualize this as an health state worse than death. About 13% of health states are regarded worse than death in this framework, which comes from criticisms, as we will see next in the next slides. But this is how we estimate QALYs. Okay. Okay. Let's make this. Okay. Okay. Let's make this with an example. We already did this in the table, but let's say that we are valuing health state at levels 3 for the first one, at levels 2 for the second, level 4 for the third, and level 3 for the fourth, and level 2 for the fifth dimension. So how we estimate this is adding, or we can explain subtracting the how many decrements we have. So for the third state, we will reduce 0.058, and then because mobility 3 is valued at that, slight problems, and so on. We will reduce the value of each health state, okay? And then we will have the final outcome, which is 0.613. How we interpret this? So one additional year of life with all these characteristics will be valued at 0.61 QALY. So as you can see, we are penalizing the additional year of life because this additional year of life has some problems. If there were no problems, then 1 year of life will be valued at 1 QALY. So this is, I think, the takeaway. So we have, remember, two times. One, we apply this instrument to our population in our study, and we have a table that we apply for the population, and then we just map this from our study to the value set that comes from the population, and then we add, and we have these QALYs estimated. Okay. And this is a graph that represents how we can conceptualize the effect of the additional treatment. Okay, this area here is representing a hypothetical situation without treatment. So what will happen is that they start at full health, which means no any issues with any dimensions. And then, okay, sorry, it's full health here. Okay, slight problems, okay, a bit less than full health. And then what will happen is that without treatment, with this kind of illness, there will be a decrement in QALYs because some problems will appear. And then another decrement, and then comes death. So with treatment, hopefully what we will have is an extension of life, okay? From death A to death B, which is increasing in time, okay? So we'll have an extension of life, but not only that, we will have also an increase in quality of life, which means that the extension of slight problems will be increasing, and then the decrements of quality of life will be also decreasing. So remember, in my first example, extension of life with cancer drugs, we are just measuring this line, the time of death. So the extension of life, this is the only one that is measured. But now we have another dimension, which is the quality of life, which make this uh, more interesting because we are not just measuring the extension of life, but also uh, if this extended life is enjoyed more or is having less problems. So then this will be the situation with treatment. And the difference in these areas will be the additional QALYs gained from the treatment. So this is how we will measure the QALYs in our example. And over to you, Valerio. Sorry, if there is any problem, any questions? Happy to take that. Or not, we can answer at the end. So over
Yeah,
to you,
yeah,
Valerio.
that's fine. Oh, thank you, Misael. I'll share my slides again. Okay. So Misael described in depth all the characteristics of the QALYs, and I think it will be clear how things are calculated now in terms of the QALYs, and also will be clear why the QALYs are so widely used in health economic evaluations. I mentioned before there are quite a few criticisms around the QALYs, and I'm just going to give you a slide summarizing the main criticism of the QALYs here. One is about equity concerns. First of all, for example, the notion that a quality is a quality regardless of who gains and who loses it, that will open up some equity criticism around the qualities because it might be the case, for example, people who won't be in a position to accrue a lot of increments in their quality of life might be discriminated by, a decision-making process which relies on quality. So, for example, older people, people with chronic conditions, people with disability might be discriminated by such a system. At the same time, there is also some leeway in the way we consider intervention, for example, for cancer care interventions, and this will be explored a bit more in session 5. So in terms of the threshold that it is used for cancer care intervention, there is a bit more leeway in the way we evaluate the cost effectiveness. And that if you think about potentially cancer, of course, eating, let's say, more older people, again, there might be some discrimination towards younger people in this case. So it's not always clear whether QALYs is an equitable way to calculate the effectiveness of an intervention. Um, Another criticism is around whether the QALYs is really capturing all the relevant aspects of an intervention. So we focus a lot on the effectiveness, the healthy years, but there might be other things which might be important regarding the process of care, how the intervention is delivered, whether it's acceptable or not on the part of the patients or the healthcare professionals. And there's also some disease-specific outcome measures that are potentially more attuned to the nuances of specific conditions, and in that sense, they capture a bit better the specific characteristics or specific repercussions of a specific condition compared with the QALYs. At the same time, these disease-specific outcome measures don't have a value set, so we can't attach utilities to the health state of these disease-specific outcomes. So that is a limitation, but at this QALYs from generic health-related quality of life instruments are so widely used because we have a value set. We can understand the utility of different health states. Capability. Now, this is about potential alternatives to QALYs, where rather than focusing on the health status of people on a specific day, we are looking at things more dynamically. So we're looking at whether people are capable of doing and being, and especially if you think, for example, at specific attributes, specific dimensions, which are not captured in the UQFD, for example. So a person can have severe mobility issues, but they can still be able to enjoy life, have attachment, have autonomy, have a sense of achievement, stability. So these are all things that are a bit more dynamic than rather than just capturing a snapshot of health status of a person in one specific day. And these dimensions that I briefly mentioned a few seconds ago are all captured by another alternative instrument, which is the IceCap, which is all about the capability of being and doing. So it is a separate, let's say, strand of research which tries to focus on the capability of people of being and doing things. Externalities are again very important. With externalities, we mean any, for example, spillover effects an intervention might have on other people. So if you think again of people with or patients with cognitive impairments or with disabilities, the interventions which might help them with their quality of life might also have some effects on other people, like their caregivers. Okay, so it might be important to capture the QALYs for those people as well, rather than focusing on the patients only. So there are certain situations where the patient's QALYs might not be enough. We need to also explore the QALYs which might be accrued by other people. If you want to know more about all these, all the elements of the QALYs and the criticism around the QALYs, we explore all these a bit more in a specific QALY vlog. I'll leave you the link there, and you can have a look at the vlog in your own time if you're interested. Now, we focus a lot on effectiveness outcomes. We focused a lot on QALYs today, and we touched upon, of course, on net cost. But if you look at this value flower, and there are I'm sure other value flowers or value framework that you can see in the literature. There are other aspects which might enter the decision of funding a specific intervention or not. With, for example, here we see productivity, family spillovers, which I covered a few seconds ago, the value of knowing, insurance value, fear of contagion disease, and so on and so on. So each jurisdiction, for example, the UK or other countries, might have specific things that go beyond cost effectiveness that are still important in terms of prioritizing or securing funding for specific interventions. So the QALYs is not the be all and end all. There are other things that could be considered as part of a decision-making process around specific interventions. Discounting. Discounting is something that you will see in your own paper, so I think it's important to cover this briefly now. Discounting applies to future costs and outcomes. So there might be certain costs and, of course, outcomes like QALYs that are going to be accrued not today, but in future years. And it's important to understand how to value this. And it's a matter of opportunity cost again. So if you think about future outcomes in terms of health, for example, the more we accrue today in terms of health, the less we might need further gains in health tomorrow. So if we are reaching a position where our health state is already quite good, then we are going to value further gains in health a bit less and less. The same way with cost, there is the law of diminishing returns. So the more you invest in something, the less you're getting in terms of return on investment as well. In that sense, we do apply a discounting rate to future costs and outcomes, which at least in the UK is equal to a 3.5%. And that means valuing our future costs and outcomes a bit less than what we would value our present costs and outcomes. This is the formula we use to discount future costs and outcomes. And you can see in your papers if the authors applied a discounting rate. Usually, if it's a UK paper, that will be the discount rate, so 3.5% per annum. But in other countries, this might vary. Or it might be the case that because of the short time horizon of a study, if it's just, for example, 1 year or less, no discounting was applied. So there could be, of course, study designs, so time horizons that don't allow discounting to be applied because it wouldn't make a lot of sense. Okay, so I'm going to talk about the homework, and then Misael and I are happy to stay for another 5 minutes if you got any further questions. So the homework is about outcome data and discounting. And we're going to ask you to try to complete this homework by Monday, the 13th of July. But if you need more time, as always, that's fine. It's not a strict deadline. You will find the homework documentation on Teams. So if you click on section 4, outcomes, open that folder, you will see a document with your name. And similar to previous homeworks, you will have a table to fill in. In this case, it's all about outcome data. Uh, so you'll have the type of outcome data you will need to extract, the question. For example, if it's a clinical effectiveness outcome, try to see whether the authors used clinical effectiveness outcomes or maybe they used the QALYs. So try to look within the paper, specifically in the methods section, but also the results table, what kind of outcomes the author used. And then in the last column, we are going to ask you to just extract that information and try to fill in that table. This is for clinical effectiveness outcomes, composite outcomes, and discounted. It might be that, like I said before, you only have one type of outcome, okay, and maybe not both. So just look at your paper, and if you need any help, the team leads are more than happy to help you with any questions. So this is the end of today's session. I'm sorry we went over time a bit, but the next session is on Monday, the 13th of July, same time. And then we're going to cover a bit more the results side of the economic evaluations. And if you got any questions on today's session, Misael and I are more than happy to answer any questions now. And we will see you next time in 2 weeks' time. Thank you very much.
Thank you.
Thank you.